Good afternoon. I'm Simeon Harris, and I'm here with the Gwinnett NAACP for our Sunday conversation where we talk about the happenings here in Gwinnett County and try to provide the information that we all need to know as residents here in Gwinnett. We have a great agenda today. We're going to be talking about some housekeeping things, voting, elections, as well as some election dates. And we're also going to be graced with a great speaker, Dr. Camara Jones, who has some great information in relation to healthcare, racism in healthcare, and the opportunities and difficulties that we might be dealing with right now. So with that in mind, I'm going to pass it over to our NAACP Gwinnett President, Penny Poole. Let me unmute you there, Penny.
Okay.
There we go.
Great. Hey. Well, good afternoon, everyone. It's a pleasure to be here before you. And we are excited about how we are moving and working together with allies and friends and collaborators in Gwinnett County. We hope that you're all safe, that everyone is well, and that things are just great for you during these difficult times that we're in. But without further ado, I would like to go ahead and introduce our speaker for today. Dr. Jones is a family physician and epidemiologist whose work focuses on the impacts of racism on the health and well-being of the nation. She seeks to broaden national health debate to include not only universal access to high-quality health care, but also attention to the social detriments of health, including poverty and the social detriments of equity, including racism. She is also the past president of the American Public Health Association and also a friend of, or a colleague of my friend, Howard Wexler. Without further ado, please let me introduce you to Dr. Camara Phyllis Jones. Welcome to the NAACP Sunday Conversation. Welcome, Dr. Jones.
Thank you. And I'm really delighted to be here. First of all, thank you for, Penny, I'm glad that you reached out to me. And I'm a family physician, as you say, an epidemiologist, and I have been getting some attention recently in the media for the work that I've been doing for decades, because my work has been on naming, measuring, and addressing the impacts of racism on the health and well-being of the nation. So a few weeks ago, when Milwaukee County was the first one that released the data showing that compared to the Black population in Milwaukee County, the numbers of people who were being diagnosed with COVID-19 were about twice the representation in the population, and the number of folks dying from COVID-19 was 3 times the representation in the population. That started people really asking, well, we need to be looking at data from other places, and what is this about? So I'm going to tell you what I think it's about. Then we'll have time for some questions and answers. Then there are 3 other things I want to hit on in our conversation today. The second thing I want to hit on is what's up with testing in this country, and what do we really need to be thinking about with regard to testing? What are the different types of tests, that kind of thing. Then we'll have some more time for question and answer. The third of the 4 things that I want to talk about is what's up with Georgia reopening like this, and is it safe, and what can people think about doing? And there I'll be learning more from you guys perhaps than giving you suggestions, but it's premature. That's all I've got to say. It's premature for Georgia to be opening up. So then we can have more discussion. And then the last little piece that I want to talk about is I am going to be talking about racism and how this COVID-19 thing has just basically ripped the sheets off of the stark unequal distribution of opportunity and exposures and resources and risks in this nation that have been created by this racist system that's foundational. But even when COVID-19 is over, we cannot let people fall back into what I call the slumber of racism denial, because most people in this country, maybe even most people today, if you were to ask them, would be in denial that racism continues to exist. And, you know, people sort of wake up when something happens like Hurricane Katrina and like, oh, why is it all the Black folks on the roofs? Or, you know, with the poisoning of Flint, the water supply. Oh my God, why is the Black city the one? Why are all the Black cities in Michigan the ones that had an emergency manager? So, every now and then people wake up and, oh, maybe there's racism going on. And then this nation falls back into the slumber of racism denial. So the last piece that I want to have a conversation with you guys about is, how do we organize? How do we communicate? How do we strategize so that this nation does not slip back into that racism denial? And what does an anti-racist policy agenda really look like? So to the first point, when we first heard about COVID-19, which was first recognized in December of 2019 in China, and by January, like people, like I knew, my sisters knew, like time to get some masks, like people sort of knew that there was something really big coming down, that this was going to be a pandemic. And the way that I even thought about it, I was telling my friends in the end of February and March that I felt like, it's an image, like I lived on a seashore, I had felt the earthquake, I knew the tsunami was coming, and yet I was watching the children playing on the beach, collecting shells and fish. That's how I felt we were as a nation, kind of unprepared, right? But we heard that this thing was an equal opportunity infector, and in fact it was. That this virus, that there was no human on this planet that was immune to this virus. All of us were susceptible. And so we would have expected, if opportunity were equally distributed across the world, or at least within a given country, if exposure to risk were equally distributed, that there would be no way that we could slice and dice this population and find differences in the numbers of people who were getting infected and the numbers of people dying. So when these data, starting Milwaukee, and then we saw New Orleans and Chicago, Detroit, more and more people started releasing their data showing that Black folks were getting infected more and dying more, even over their infectious rates. The question was, what's up with that? What it really showed is that opportunity is not equally distributed in this country by race, and exposure is not equally distributed, resources and risk. And there is a name for the system of structuring opportunity and assigning value by race that is operating in this country, and that is racism. That my definition of racism is a system of structuring opportunity and assigning value based on so-called race, based on the social interpretation of how one looks. And it has three impacts. It unfairly disadvantages some individuals and communities, but every unfair disadvantage has its reciprocal unfair advantage. So it's unfairly advantaging other individuals and communities. And that's the whole issue of unearned white privilege that we hardly ever talk about in this country. And finally, even though you have this seesaw between the unfair disadvantage, unfair advantage, racism is actually sapping the strength of the whole society through the waste of human resources. So then, I was getting up on the news and I was saying racism. I was saying the word because I think we need to name racism, right? That's one of three tasks if we're going to have a national campaign against racism. But then people were saying, but how could racism be doing this? Well, actually, it's the same way that racism causes twice as many of our babies, of our Black babies, to die before their first birthday compared to white babies. It's the same way that racism causes 3 times as many of our mothers to die in childbirth-related deaths compared to white mothers. It's the same thing that causes us to have 60% more diabetes, 40% more heart disease, all of this stuff. So racism has been at the root of all these health disparities that we have just come accustomed to. But these Black bodies with the COVID-19 were just piling up so fast and so unexpectedly that people couldn't ignore them, right? And couldn't normalize it. So here's my analysis. Racism is causing more COVID-19 deaths in Black folks compared to other folks because we are more exposed, we are less protected, we are more vulnerable health-wise because we have carry more of a burden of excess disease because of the conditions of the communities in which many of us have been segregated. And the last piece is the only piece about healthcare. We have less access to healthcare and the healthcare that is going to even respect our lives. So let me go a little deeper on the more exposed, less protected, more vulnerable because of the chronic conditions that we carry more in our bodies, the burden of living in a racist society, and less access to healthcare. So you see, it's not a big healthcare thing. More exposed because of the kinds of jobs that we have, being on the front line, being, you know, maybe not even being, we're certainly not overrepresented among the physicians, but we are overrepresented among the folks cleaning up the hospitals or the CNAs and the like, you know, turning the patients, the food service in the hospitals, where even those kinds of jobs right in the hospital for the first few weeks, months maybe, weren't recognized as being part of the essential workforce. But we also more represented in jobs where you can't work from home. You know, so if you're a postal worker or a sanitation worker or you're a grocery clerk or you're doing the deliveries to get people's groceries to them so that they can safely shelter in place, all of this, we are overrepresented in that kind of workforce. And also we're overrepresented in jobs where we don't have paid sick leave, even if we feel sick or we need to stay home to be the teachers for our kids when the schools are closed, right? So without the paid sick leave, without the wealth to kind of fall back on, so all of that. So we're more exposed in those kinds of jobs. We're also more exposed because we're severely overrepresented among people who are jailed and people who are incarcerated in our prisons. And then brown folks overrepresented in the people, you know, in the immigration detention centers and the like. And we're also more exposed because we're more likely to be unhoused. So we're more exposed in terms of the workforce, but also in other places where we are overrepresented. Now, even in those jobs where we're more exposed, we're less protected. For example, Jason Hargrove, the bus driver who was in Detroit talking about this woman coughing all over without covering her mouth. And then 2 weeks later, he's dead, you know, like not given the PPE that other people who are now recognized to be in the essential workforce have been given. So, and we not even given hazard pay. So that's another thing in terms of being appreciated. So more exposed, less protected, therefore more infected. But then once we're more infected, why should our death rate still be another magnitude higher? So if you're twice as infected as our representation in the population, why are we 3 times as likely to die? And that has to do with the chronic diseases, which is not because we don't know what to eat. It's not because we're lazy or stupid, right? It's not because we are more vulnerable, you know, there's something genetically different about us, because there is not. It's because the communities in which many of us have been segregated, have been disinvested, have been poisoned by environmental racism. You know, if you have a racial segregation in housing, it turns into racial segregation in terms of educational opportunities, racial segregation in terms of exposure to fresh fruits and vegetables or green space where you can go out and play. And then we're in neighborhoods that have actually, there's a term for it, sacrifice zones, where we are living next to polluting industries and the like. So, and Simeon, I'm looking right now and so I don't know if people can see me big or see you big. Okay, because I'm seeing you big.
Well, we see you big.
Okay, that's fine. Because all of a sudden I was like, oh, anyway. But anyway, so it's because of living in those kinds of communities that we have more of the diabetes, more of the heart disease, more of the hypertension, the asthma, more of the kidney failure, that once you have the infection, it's making you have a more severe form of it and then ending up in death. Then these very same neighborhoods, often the health facilities, if you're not, so sometimes these are the neighborhoods which are the teaching hospitals, where the teaching hospitals are, where they teach the interns and residents and the like. But sometimes we're in neighborhoods where the hospitals have closed down because maybe there weren't as much of the elective surgeries or whatever to keep them open, or maybe they don't have all of the high-end, you know, ventilators or all of the stuff there. Also, many times we have been calling saying, I'm sick, I need to come in and get a test, and even ending up at a testing center or at an emergency department and then told, well, go home and rest. And there was last Sunday, there was an article in the Detroit Free Press entitled, "They Sent My Mother Home to Die," right? And that is happening to us more frequently.
And Dr. Camara?
Yes.
You gave us a lot of information. Maybe there's some questions out there that someone may need to ask or just.
Yes, absolutely. This is a good time, although I haven't talked about what we need to do, but maybe those questions about what do we need to do. So I am happy to stop right now.
or people just may be in situations that you're describing,
Yes.
and wanting to know, where to start first, or maybe even have, if there's anyone with some questions, this would be a great time
Yes.
to ask Dr. Jones.
Josh, I see that you had your hand up there. Did you want to come off mute and ask? Looks like you're still muted there, Josh. Let me unmute you on this end.
You see that? No, but I'm not muted.
No,
Now you're good to
we
go.
hear you.
I'm good? Okay.
Yes.
Well, first of all, doctor, I want to thank you. You had given us such a wonderful and valuable information. Quick question about this testing, that how accurate it's coming now, because one thing recently I faced it from my own family members. My brother, he went to Chile, Argentina and Brazil. Then he was in a vacation there for 3 weeks, and he got back to USA back in March 24th. And he got some fever. After coming here, I didn't see him, until actually yesterday. And he went to Johns Creek Hospital, and they kept him for 2 days. And they said that he is COVID-19 negative, and they sent him home. But when he went home, he got more sicker. He was suffering for 4 days. Then his wife called 911 and took him back to hospital. And at that time also, they did his testing again, and it came negative again. But finally, third time, they said that, yes, it is positive, and he was severely ill. He was in ICU, but luckily, thank God, pray to God that, he is good. They discharged him almost 12 days back. But his doctor was telling him that, I'm sorry that we had to discharge you from the hospital first time, because if we didn't have to discharge you first time, then today I don't think you would have been in such a bad situation. So my question is that, 3 times testing, and then it's coming negative. So where do we go? What people are going to do? And same thing also, I'm sure hospital, they're doing their job, but at the same token, when they're releasing patient and when they go home, they become worse. So how we can educate people?
Right. So there are 2 things. So the test that they're doing to diagnose the COVID-19, if the sample was taken at the time where there was the virus in the nose, and if the sample was taken well, should be positive, although there are negative tests like that. Maybe the sample wasn't taken well enough. Maybe when they did the runs of the things, they had poor reagent or something. So there are times where people have had a negative test, but usually the second test has come positive. For him to have 2 negative tests and then a positive, and to have all that suffering in between is I hadn't heard of that before. The other thing is that in some countries, so not in the US yet, if he had tested positive, they wouldn't even have necessarily sent him home where he could infect everybody else who was living at home. That's a problem with what we're doing right now, especially if people are living, several family members in close spaces or multi-generational, and somebody comes and then the mother, the grandmother's there, and they're going to get sick too, right? So in other countries, they have actually created mid-level COVID-19 centers where people can go if they're known to be positive, stay there monitored by a nurse who takes the temperature twice a day with oxygen there, making sure, because if they start getting worse, then they can be sent to the hospital. What they're doing right now, sending folks home, is infecting other people, and there's no nurse there, there's no oxygen there, there's nobody there to monitor it. The thing here is that I don't know if we would accept that kind of center. I mean, because maybe it would remind people of detention centers, or maybe it would remind people of jails. And also we would need to roll this out in a really good way, but that's a way to decrease the infection, even if we're only testing people who have symptoms, which is the other problem with our testing. The problem with our testing right now is that we have requirements. You had to have a doctor's order at the beginning, or you had to have such and such symptoms, and then they had to think that you were severe enough and all of that. So that a lot of people, we don't even know everybody who's had COVID-19, because in New York, they had so many people, more people dying at home than they did before the pandemic. And so many of those people are probably also COVID-19 deaths related to that. So, but the testing that we're doing right now, this is going to get me into that argument. So let me hear some more questions about that, because I want to talk about testing why, but I want to have other people's questions. So what I have to say for you, in your case, is the test may not have been done well enough. Maybe there was a mistake in it, or maybe the first time was too early. The second time after he was that sick, I'm so surprised. And I'm glad that they finally took him back in the hospital where he needed to be. And I'm glad that he's back home. And other people are not that lucky.
Thank you. Do we have another question there?
Yes.
Sure, please go ahead.
Hi. I did read a story about New York, and that they have reservists coming in and going through homes as well as hospitals, you know, just collecting bodies as it is, and making records of people who died from the virus now, maybe not earlier. But I wanted to ask you about your work that you did collecting data, addressing racial bias in the medical system. Where is that data, and was it nationwide? And has anyone published any like infographics or tables or anything? Do we have access to that?
Interesting. So there are a lot of people who have documented the impacts of racism on health. And even, I think in 2019, there's an amazing review of that by Dr. David Williams. So if you just Google David Williams, Racism in Health 2019, it might even have been 2020. I mean, because there've been, for about 2.5 decades, people have been doing this kind of work. You asked me if there's an infographic. I know that the UCLA Center for the Study of Racism, Social Justice, and Health has some early infographics just about COVID-19, but we're about to create one. I'm an advisor to that center. We have a COVID-19 task force, and we're about to release one on racism, particularly in this context. My work on racism in health is, there's some data stuff on it, but my gift is in helping people understand how racism works through storytelling. So I have a TED Talk, for example. So if you Google Camara Jones TED Talk, where I share 4 of my allegories on race and racism. If you Google Camara Jones Gardener's Tale, that's the one that was published 20 years ago now, which is sort of like in the public health and medical field, like to mainstream that. So I would send you that stuff. So you have the data piece, and you also have the communication piece, and like really helping people understand racism on 3 levels. Structural or institutionalized racism, interpersonal or personally mediated racism, and even internalized racism. Is that helpful?
That is helpful. Thank you very much.
And in our description, when we post this to YouTube, I'm also going to post the links to those TED Talks. I had an opportunity to watch them, and I found them super insightful. Question for you: what if someone's seeking to get tested, they're not feeling well and they're denied, what should they do, and what rights do they have?
I think that they should maybe go to another hospital or call, but then you hear the stories about people who are turned away from 4 or 5 hospitals. They don't want you to show up first. They want you to call first, and then they're going to ask you about your symptoms. Sometimes if we have a fever, we take some Tylenol, which is, people have wondered, is Tylenol better than ibuprofen or Advil? So I would take Tylenol if it were me, if I had it. We take Tylenol, then we turn up at the emergency department, and then our fever's not there anymore. Okay, so people have been turned, but you just have to be persistent, because this is your life. So I think you just, somebody said that if you show up at the emergency department, they can't turn you away. They have to at least evaluate you. So if you call and they say don't come, and then you call another hospital, they say don't come, but you really feel worried, then I think you need to just go, right? and they have to at least evaluate you before turning you back. The other thing is, if you go and they send you home, they should send you home with at least two things: a thermometer, because you should be monitoring your temperature, and this little device that goes on your finger, a pulse oximeter, it's called, PULSEOXIMETER, pulse oximeter, which checks your oxygen level. Doesn't stick you or anything, you just put it on your finger. And if your oxygen level goes below 94, some of them just say low, but if it goes below 94, you need to get back to the hospital immediately, because what they're learning about the pneumonia, that is why people have to be intubated and all of that. That pneumonia, people don't necessarily feel as short of breath as they do with other pneumonias, because the carbon dioxide is not building up as fast because of, I guess, you're breathing fast, something about this pneumonia, that you don't feel as short of breath as you really are. And your oxygen level can go quite low before you really understand, oh my God, there's something urgent going on. So if you are checking your oxygen level twice a day, or anytime you feel like something's going on, then you can know to go back to the hospital sooner.
Is the state of Georgia sending people home with those devices?
I do not know. But we should demand. And so NAACP, for example, could demand, or, that's a thing that they should be doing.
Right. And let me interject at this point, Dr. Jones. Gwinnett County specifically has been doing free testing without an appointment. And there's a number to call. It's 770-513-5631. That's 770-513-5631. You do not need a doctor's appointment. It is free. However, you need to call. You do not need a doctor's referral. Please call that number and they will give you an appointment to come in and test for free. And Gwinnett has been doing this at the Civic Center. And things have been so fluid in Gwinnett County, but please call that number and they should be able to assist you if you need an exam. Thanks for letting me put that in there.
Thank you. And Dr. Jones, if you want to go to, I know you had some more you wanted to talk about, and then I'll open it for questions again.
I just want to say, just back on this though, another thing that people have just been noticing is that even younger people who may or may not even have had symptoms of the fever, the cough, the shortness of breath, even the loss of smell that some people have noticed, but they have been showing up, younger people have been showing up with strokes and then been showing up COVID-19 positive. So if you are younger and you're not having all those symptoms, but you start feeling like you're weak on one side, or you can't talk, or some strange sensations, you need to call 911 right away about that. This is a new thing that they're noticing, is strokes, especially in younger people associated with COVID-19, even people who didn't have any of the other symptoms. So I just want to bring that to you all's attention. So, so I was going to say, what can we do as a nation because just because we see these, if we didn't do anything seeing these Black excess deaths, then we would be doing the way racism operates in the society all the time, which is lack of action in the face of need. So we need to address the increased exposure. So we need to make it as feasible as possible for as many people as possible to safely shelter in place. So the government has these one-time payments, which haven't really gotten out to most people. We need to make that not just a one-time payment. This is where political advocacy and connecting to your lawmakers and showing out, right? So we need to make sure that the paid sick leave, the enhancing of the unemployment insurance, make it not just one-time payment, but many payments, the Payroll Protection Act, where all that money to the small businesses went like boom in a flash, and many Black and brown business owners didn't even have the relationships with the big banks who were given the money. Now we have the second level of that coming out. So but we need to make sure that it is as feasible as possible for people to be protected, less exposed, right? And then the people who are still on the front lines in the postal service, sanitation, all of that maintenance, that they have the full protective equipment that they need, right? So that's on why we have more infection, more exposed, less protected. We need to make sure that if we know that there's going to be a bigger toll in communities where we have more diabetes and all that, the health resources are pushed in those places. And this, a thing that hospitals can do, that Boston has done, is that all of the hospitals in the city have agreed that no hospital is going to be rationing emergency dialysis or ventilators or any of that until all hospitals have to do that. That is, there's not going to be one hospital that has a shortage while a hospital 5 miles away still has beds or ventilators. So I don't know what kind of agreement they did, but maybe in the Atlanta area or in Gwinnett County, we have to push for hospitals to have that kind of agreement so that there aren't any local shortages. The other thing is that they, at least here in Massachusetts, have been talking, they have come up with what they call crisis standards of care. That is, when the usual doctor-patient relationship and doctor-patient-family relationship goes out the window, things are like a war zone, and we're going to be rationing stuff. And we have 3 patients who need a ventilator, and we need to decide which one gets it. And so these are the guidelines that they're developing for that kind of situation. First of all, we have to reject the scarcity model. There shouldn't be scarcity anywhere because it's a big country. Not everybody's feeling it the same way. If we know that there's a big pandemic in Georgia, or I would say now that we're reopening Georgia, we know there's going to be a big one. We need to be moving the health resources and the personnel to Georgia. Shouldn't just be California deciding they're going to send something to New York or New Jersey. There should be bigger coordination. But anyway, here we are in the country the way it is. But there shouldn't be the local shortages, but if there are, and if there are these crisis standards of care, they should not be penalizing people for having diabetes or heart disease or any of these things, right? We should not be disqualified from getting that care or even made lower on the priority list for that. So that's a very important thing, kind of a policy thing we need to push for. I have actually suggested that we use a lottery system to allocate scarce resources if they were scarce. If we all agree that we're going to use a lottery, you know the resources wouldn't be scarce, because you know that head of the hospital would not let it be a lottery that would determine whether he or she got that last ventilator, right? You know, so if there really were a lottery, then we would find ways to make there no scarcity.
Okay,
So, yes.
Dr. Jones, we have another question. Constancia, who had problems speaking before, let's unmute her and see if we can hear from her right now.
Absolutely.
Constancia, are you available to talk?
Yes, can you hear me?
Yes.
Okay, good, thank you. I apologize for the error earlier. My question is twofold, and I guess it goes toward what you were suggesting with respect to solutions. The first would be, to what extent does the privatization of healthcare, privatizations of hospitals, hamper a rapid response to these types of public health crises? And then to what extent also does traditional methods of public health communication and education need to be tailored to reach those more at-risk populations, to give them information, needed information regarding protecting themselves in crises like these?
Okay, so thank you for both of those questions. So I'm going to answer them, and then it takes me just into another subject as well. So because we have national networks of hospitals that may not feel a big allegiance to a given, so, they have a hospital in Gwinnett County and they have a hospital in Santa Clara County in California, whatever. So that may hamper the kind of regional collaborations and cooperation that I was talking about. And the privatization of hospitals means that often it depends on if they're still a not-for-profit or not. So it could be privately held, but if it's a not-for-profit, then all of the so-called profits should be put back into the healthcare. But there's some systems where profit may be sent out to shareholders or the like, and that's really not a very good model. So I don't know. So in terms of working together on a regional basis, I don't know if that's going to be interfering or not. I imagine it could. In terms of the tailoring of public health messages to specific communities, the Centers for Disease Control and Prevention, when we had the avian flu scare and the H1N1 scare, H1N1 pandemic, they actually had a separate group that was about pandemic preparedness in vulnerable populations, who develop the messaging and the outreach strategy and which organizations and, getting people, preparedness tests and all of like that. That was back in the, the 2010, 2011, perhaps. And that existed. So why hasn't it been rolled out now? Well, why hasn't CDC been anywhere in this at all? So my take as somebody who worked at CDC for 14 and a half years is that that the COVID-19 pandemic is a public health problem, but it has not been handled as a public health problem. It's instead been allowed to become a medical care problem. But if we had done all of the testing and then the tracing, the contact tracing and the isolation and the quarantine and all in a public health way, then we wouldn't be seeing what we're seeing right now. So the same lapse in terms of getting messages to vulnerable populations is just a tip of the iceberg of the huge lapse that CDC has had in leading this pandemic. So somebody has muzzled CDC. If CDC had not been muzzled, this is what we should have seen. And this is what we still need to see right now, even though we have hospitals being overwhelmed or almost overwhelmed in many parts of our country now. The kind of testing that we are doing right now, where somebody has symptoms, and then if their symptoms are bad enough for them to be admitted to the hospital, or they're bad enough to impress somebody in the ED or on the phone, then they get tested. That is just about confirming a diagnosis in a single individual, one by one. When we test that way, yes, we'll be able to document some part of the pandemic, although we actually are missing a lot of people, as was alluded to before. But we're documenting the course of the pandemic, but we're not able to really change the course of the pandemic with that kind of testing. The kind of testing that we need to do to change the course of the pandemic, and the kind of testing we need to do to open up any of these states or cities or regions, is a public health model, a population-based model, where we test periodically a sample of the population, of the whole population. Some will be symptomatic, some will be asymptomatic, right? I actually think we should test everybody who wants a test. Everybody who's symptomatic or even just curious should get a test. But there's other kind of testing to help us know how much infection is there right now in the community, would be based on a probability sample of the community. It would be done maybe every week on a different probability sample to say how much infection is there out there right now, including of people who are asymptomatic. Once you get that estimate, it does a few things for you. First of all, you have an idea how much infection is there today, which is going to be telling you where and how many resources you have to put in your hospitals 2 weeks from now. If we're just testing people who are already in the hospital, that is a 2-week-old picture. A 2 or 3 week old picture. That shows how much infection there was in the community 2 or 3 weeks ago. It's like a Polaroid that's slowly developing. If we find out how much infection is there now, we'll know where we need to put our hospital resources. We're also identifying infected people who are asymptomatic. So now we isolate them. We ask them, you need to stay at home. Or if home is not good because you have your grandmother there, then we need to really be finding dormitories or hotels that are, have rooms now. We need to be setting up those kinds of centers where people don't have to go back home and infect other people, but they can be monitored. Then we do the contact tracing, not just for the symptomatic, but for the asymptomatic. So we've already taken one asymptomatic spreader out by isolating that person. But then we find out about their contacts and we let them know you have been exposed, and we ask them to isolate as well. We have done 2 generations of interrupting this exponential spread. So we're not just documenting the course of the infection, we are actually controlling, altering, changing the course of the infection. Every single epidemiologist at CDC, every single public health worker knows this is what to do. Why CDC didn't step out there, why we have this false scarcity of tests, why we didn't ask WHO for their test, right? We could have asked. WHO is giving their tests to low resource populations, but any country that wanted it could have asked. There are so many mysterious questions about this. Why the Defense Production Act was not ramped up in terms of testing, yes. PPE, the personal protective equipment, yes. And ventilators, yes. Why it still hasn't been fully ramped up, I do not know. But the fact that we have treated this public health problem as if it were a medical care problem, one by one patients, which has turned it into a medical care problem, is beyond me. I will stop and see if there are other questions, because then I want to link into what we need to do to open up Georgia again, and when. Are there other questions?
With the time, if you can go right into what we're doing to open up Georgia, or what we need, that'd be great.
Okay, yes, I'm sorry, I've been talking long.
No, it's been wonderful, and we really appreciate it.
Okay. So, so first of all, it is premature for us to open up Georgia. So the World Health Organization has 6 criteria that have to be met. The Trump administration has put out 3, and I'm sorry, I don't have them at the top of my mind, but the first one is that the rate of hospitalizations is going down steadily for 14 days. In Georgia, the rate of hospitalizations is going up. So it's not even going down. And you know, if it went down today compared to yesterday, that's 1 day, not 14. And as I have said, hospitalizations are just a picture of the infection 2 or 3 weeks ago. We really need to put in place the kind of testing that is on a random population-based sample of people, not even just symptomatic people. Glad that anybody can call and get, go get the thing at the free testing. But we need to have a public health surveillance approach to testing. And we need to be doing that periodically, twice a week or at least every week. And I would say, I would need to see that prevalence going down at least 2 weeks. I would prefer 4 weeks, where we see the prevalence of the infection, of the real prevalence of the infection, not a hospital 2 or 3 week old picture of where it was 2 or 3 weeks ago. That's not good enough before I would feel comfortable opening up. And then we need to still do the testing, and we need to overrepresent, we need to oversample the testing, not just population-based. We can oversample in those communities that we already know have been hit hard, and in the prisons, of course, which we need to decarcerate, you know, in among unhoused people, where we need to find them housing. We need to do it in the nursing homes. We need to do the testing of everybody that's in those, but we also need this other prevalence stuff. So it is premature. Now, I understand that, for example, Mayor Keisha Lance Bottoms of Atlanta is saying she is not going to recommend people go back to work in Atlanta, and it's going to come to a legal thing. Spencer Overton, who is an attorney who works with the Joint Center for Political and Economic Studies, we were on a call together on Thursday, said something that I thought was brilliant. He says, the relationship in these kinds of public health things between the state and localities, you know, the cities or counties, is not settled law yet in the case of something like this. So if there were something, the state cannot just say, oh, you cannot have something that's stricter in your city than what the state is doing. They might try to do that, because I've heard that maybe Texas did that already, or maybe it's Florida, some state has already said that. But so there would have to be a lawsuit, right? There'd have to be a lawsuit filed while the city's still telling their people, you can stay home. In fact, we recommend that you stay home. And then, you know, so that goes to a local judge who has to do all of the finding and, you know, all of that. It might take some time, right? And then they do the thing. And then if it's taken, you know, this might take some time, which might be the time that we need, you know, for us to really get the testing, you know, for us not to push people into harm's way. We have to be clear that our people on the front line who have been affected more severely can be expected to be affected more severely, you know, and even though we're a right to work state, I mean, there has to be some organization of labor. There has to be something. I spoke to somebody in John Lewis's office. He's my representative. And I was saying we need to have something like a conscientious objector status. We cannot have people forced, you know, to go back to work, because if they don't go back, then they're fired. And, you know, what does that say about what they can get in terms of support? So that's on that. That's my thinking, that it is premature, and that there are things that people should not be put in a place where they think, I either have to get food on my family's table, you know, and the only way I have to do that is to go into harm's way. That should not be their choice. So it shouldn't be health over, you know, over work. The last thing I want to say is, I think that, so the fourth thing I want to say is, after all of this is said and done, we cannot let this nation go back into what I call the somnolence or the slumber of racism denial. When I was president of the American Public Health Association in 2016, I launched our association on a national campaign against racism with 3 tasks. The first is to name racism, to say that word. Don't be shy. You know, it's good to talk about, you know, race, or good to talk about, implicit bias or disparities or discrimination. Those are good things to talk about, but we have to talk about racism because that's the system that makes race have any pertinence in the first place. We need to name racism. We need to identify the mechanisms by which it's operating, which are all in our decision-making processes, by asking the question, how is racism operating here? Looking at the who, what, when, where, how, and why of decision-making, especially who's at the table and who's not, what's on the agenda and what's not. And finally, we need to organize and strategize to act. NAACP is like right positioned right there to help organize and strategize to act. And if I were to name my 3 top policy agenda things for an anti-racist agenda, the first would be reparations for descendants of Africans enslaved in the US. My colleague Vernelia Randall, an attorney in Ohio, says DAEUS, D-A-E-U-S, is an ethnic group that we need to identify, descendants of Africans enslaved in the US. We need to have reparations for us. We need to have decarceration, abolitionism, all of this. Angela Davis, way back in the day, was talking about decarceration as a platform, right? Because we are first of all, the United States incarcerates a much higher proportion of any of its population than any other country in the world, and we are overrepresented in that. That's the second. And the third is huge investment in our communities, and especially around our children, so that nobody could say the words disadvantaged child and have it any meaning, because there should be no child who is born into disadvantage. So I will stop here and get other people's questions or comments.
Wow, we really thank you for all that. We need to make sure that we can share your information with our listeners in case they needed to ask more questions. There was just not enough time to get all of that information. So I know we're gonna have to have a part 2. So again, we thank you, Dr. Camara Phyllis Jones, for being our guest this Sunday on our Sunday conversation. And I guess at this point, we're gonna try to quickly wrap up and just touch some updates that we need to hit on before we leave. But again, thank you.
May I stay and hear the rest of the business meeting?
Please, we would love for you to. Okay. We would love for you to. First of all, thank you for acknowledging the NAACP, because we are collaborating, we are making allies. And I want to specifically recognize our Atlanta Metro chapters with Richard Rose as our president, and also our state president, along with the Atlanta Concerned Black Clergy, who stood up against this new executive order that was issued by Governor Kemp, which removed the staying at home and remove the orders for people to have safe spacing. So again, we thank you to all those groups for standing. Also, we just need to recognize what you had spoken about, the institutionalized racism that's now just coming down on our communities, the marginalized Black and diverse people, the working poor, the people who are dealing with the institutionalized racism regarding their housing, employment, resources, and not having the advocacy to speak for them. Because what is happening now, these people are being denied resources of the monies that came down because they have late rent payments, because they have not paid their utilities on time. People are being put out of their homes. And they're not getting the stimulus funds. They are being targeted not to receive stimulus funds. And then we also have heard from people whose children were unable to receive Chromebooks. We're asking all of you, please call us at our office, 770-400-2929. We have been reaching out, making allies, and collaborating so that we can make resources and contacts available to assist. So please give us a call. We have this. And I want to rapidly move to voter registration. We had a lot of information on this. I can touch the highlights, but the most important thing is to remember to send in that application for your absentee ballot. Please remember to register to vote by May 11th, because we need you. The NAACP is asking for volunteers. Our PAC chairman is Amira Lawson, She is asking for volunteers to help call and reach out to the community. And most importantly, on June 9th, please, please, please pick a party, because if you do not pick a party, you will be unable to vote for the nonpartisan candidates, because the judges will be elected. So you have to pick a party to go down that ballot, and then at the end, the election for the nonpartisan judges will be held. And certainly last but not least, we want to make sure you check your status. Just make sure that you're still on the rolls, that you have not been purged. Your Gwinnett NAACP, we're working hard to make sure that we're bringing you this information. I am going to just stop this really quickly. I want to ask you, Simeon, do you have anything else you need to say before we have our words of inspiration?
Really quickly, just to understand the impact of the upcoming election. These are all of the offices that are actually up for election. You have president, vice president, U.S. senators, 1, U.S. House of Representatives, public service commissioners, 3, state senators, state House of Representatives, district attorney, clerk of superior court, sheriff, tax commissioner, the chair of the board of commissioners district 1 and 3, board of education districts 1, 3, and 5, superior court judge district 6, 6 superior court judges candidates, state court judge, probate court judge, and chief magistrate. So there's a lot up there to vote for. A lot of research that you're going to want to do to make sure you know what candidates represent your needs.
Okay, and before we take it over to our words of inspiration from Pastor Willie Godman, I just wanted to remind you, next week we will be talking about the census, and our very own Vanessa Thomas will be bringing that message to you. She is wanting to make sure that everyone is registering and letting each and every person in your household, from those not born yet to the oldest, that they are counted. So Vanessa Thomas will be here with us next week, and she has a lot of information. And right now, what we're going to do, we're going to say thank you. We're going to ask that you keep safely in place, but we want to introduce Pastor Godman from Mount Carmel Baptist Church in Duluth. Pastor Godman.
Yes, good afternoon, everyone. Thank you, President Penny, Marshall, and Brother Simeon. Thank you for your technical support and everything. And Dr. Camara Phyllis Jones, thank you, thank you, thank you, thank you. We understand, have heard often before, people perish for lack of knowledge. People perish for the lack of knowledge. And I am clear at these days and times that our Creator is intentional about helping us to have access to information, access to knowledge, access to persons with understanding and insight to encourage us toward our best destiny, to live our best lives. And so I'm grateful for this opportunity. And I want to encourage us to encourage the Gwinnett chapter in NAACP and all those who are connected and so affiliated directly and tangentially. I want to encourage you to keep doing the work. Keep doing the work. The reign of God does not come lightly. It does not come easily, but it comes by force. It comes by those who take it and make it so, and to deliver it. That sounds kind of radical, and we get kind of concerned when radicalism, which is often painted negatively, is connected with political action as well as church work. But take a look at the chief carpenter, the lead carpenter, the one who taught us how to live, who showed us that first action in order to help people, in order to support folks, you got to feed them and take care of them and then teach them. And so that's what we're doing. That's what we're doing. We're helping us to learn so that our souls and our minds and our spirits are fed and taken care of. Then we can push and press for the well-being of our families and communities near and extended. So I want to thank you. I want to encourage you all toward this work. At times it may seem to be overwhelming, but this is not anything that we cannot do and cannot get done, because our God has committed to us. We are committed to each other, And our ancestors have prayed for us to come to this day, to arrive at this time. And so we are the very living evidence, the very living proof of their answered prayers. And so we are here. And so now it's the time for us to do the work that we have been called to do and challenged to do. We have everything we need to get it done. Have everything we need to get it done. My mind is thinking faster than my mouth. I'm just so excited to be a part of this conversation, and grateful, So I want to encourage us. The last thing I want to say, Black Moses said she could have saved more if they had known they were slaves. She could have saved more if they had known they were slaves. The first challenge is to help us to know that we have the authority and that we have already been set free. We have already been set free. And enslavement was not our first station in life, but it was something that was pressed upon us. And so the residual effect continues to monocle our minds and our hearts and our souls. Now take off our own chains and release ourselves from our own prisons, and learn what we need to learn in order that we help ourselves and our people. And not only our people immediate, but extended communities, because if anyone's bound and locked away, then everyone's bound and locked away. But if we're free, then all of us are free. So I want to thank the Gwinnett chapter in NAACP and all of us who are connected to do the work. I want to encourage you to continuing, press forward, press forward, press forward, press forward. For the strength you need is already available to you. Peace and blessings.
Thank you very much. And again, thank you for all coming tonight or this evening. We also want to shout out to Let 'em Eat Gwinnett. Last week, we served over 1,300 meals in 5 locations in 5 days, and as well as Mount Carmel being one of the spots and locations that we attended. Again, Let 'em Eat Gwinnett. And we're still out there. We'll be out there next week. And please send your donations to Let 'em Eat Gwinnett, and you can get that on their website. So we're excited about that project, and we're looking to feed even more people this week. Again, everyone, we thank you for your participation. We thank you for listening. Please tell a friend. This information will be recorded and posted. Simeon, let me let you take it out. Take it out for us, Simeon.
Dr. Jones, you rock. Thank you so much for being here today, and thanks everyone. This will be posted on YouTube by tomorrow morning. Everyone who was on the invite list, I'll also send that link directly out to you, so please feel free to share it. And thanks everyone for joining. We'll be back next week at the same time. You all have a great rest of your Sunday.